Providence, Alaska, Project Echo Dementia. I'm Chris Rhodes, a neuropsychologist at Memory and Brain Wellness at the University of Washington, down here in Seattle. And you're a co-lead for this wonderful project. I'm going to go ahead and share my screen, which I know will stop our CME screen. Thank you for that. So we have a fantastic program today, including a didactic on advanced care planning for dementia by Dr. Barack Gaster, and then a case by Barb Bigelow, which will be our second half here. Here we have our hub team members, and I see Barb is joining and connecting to audio. So our hub team members, we aren't going to do introductions given time, but thank you, Barb, for joining and helping out with the case today. Very much looking forward to that. So we do have CME credits, and that is through the Swedish system. We do not have any disclosures that are relevant in terms of any financial interests. There is a mitigation process whenever there are any financial disclosures necessary. Here is the process and the code for CME, again, through the Swedish portal. And please, again, do both submit CME for the parts that you've attended, and do let us know if you ever perceive any kind of conflicts or issues. So it is my pleasure, it looks like we've got a few more folks who are joining, my absolute pleasure to introduce Dr. Barack Gaster. He is a professor of medicine and a primary care provider with expertise in the evaluation and management of dementia. He has 20 years of experience as a primary care provider and is currently director of the CDC-funded Cognition and Primary Care Program at the University of Washington. He is a member of the CDC's Healthy Brain National Leadership Committee and is an invited member of the Hastings Center Work Group on Ethics and Dementia. He co-developed the Dementia Directive, which has been downloaded more than 150,000 times and has been featured in the New York Times and on NPR. So it is with pleasure that I introduce Dr. Gaster, and I will turn it over to you.
All right, and I think you need to stop sharing for me to be able to.
There we go. Try that.
All right. All right, thank you so much, Chris, and thank you all for having me again. My name is Barack Gaster, and I'm a primary care doctor who has been working specifically in the dementia in primary care field for about 7 years now. And so it is my pleasure to give you a brief overview of the specific case of advanced care planning for dementia. And so let me start talking a little bit about why is dementia unique, because I think it's important to say that, you know, there's not like we need a specific advanced care planning for every disease that's out there. Some diseases have specific issues that are germane to advanced care planning, but I think that dementia really jumps out as maybe the one that has the most unique features that makes it special for advanced care planning. And part of it is that so early in the disease, people lose the ability to guide their own care, and so others have to make decisions on their behalf, and that goes on for many years. That the course can be very rough, that about 80% of people with dementia do go through a phase of being agitated and often combative. And so there are people who sort of look at that and like, you know, wow, that is really an intense way to be living. And I really, you know, have maybe strong feelings about what medical care I would want if I was going through a situation like that. And so, I mean, really, there are a lot of people who would want a gradual shift to comfort-focused care, but trying to decide when and who decides and how to decide is really, really complicated. And this is such a huge issue. I mean, you guys are all here, so you all are aware of just what a big problem dementia is, that right now more than 6 million Americans are living with dementia, about a third of people over age 85. And it's really this projection over the next 10, 15 years of how much the number of people living with dementia is expected to increase. And that really it's as the baby boom bubble moves into the age range of being at high risk for Alzheimer's and other types of dementia, that there really is a solid demographic projection that the number of people living with dementia is going to double in the next 20 years. And so if we think this is like a hard issue that we're facing right now, it is really this future projection that really should give us all pause, which really is this kind of silver tsunami that is potentially on the horizon. And so it really, I do think of this as the number one disease challenge that we face, and that advanced care planning is such an important part of meeting the challenge. And so I think it's really good to have just a definition at first of what is advanced care planning about. And I really think of it as better care, that when we align the medical care that people get with the medical care that they would have wanted through advanced care planning, that is really widely seen now as higher quality care, better care. And so it's first also important to think about what's in a standard advanced directive, because so many people do have this false sort of reassurance that they filled out a standard advanced directive, and so they've got it all taken care of. It's, they did this thing that we have been harping them to do, and so now if they're done. The problem is that there's almost no guidance about dementia in the standard advanced directive that is really in every state's standard form. So state of Washington, state of Alaska really has nothing in their standard advanced directive that really pertains much to dementia. The main focus of almost every state's standard advanced directive is on these relatively rare conditions, which are permanent coma or persistent vegetative state, which are important disease states to express your wishes for, because when they do occur, it is really hard and often difficult. But these are like 1 in 10,000 or 1 in 50,000 risks that any of us would ever be in a permanent coma or a persistent vegetative state. And it really gives no guidance. And the number one reason that people lose decision-making capacity, which is dementia, which, like I said earlier, it's like maybe a third of people as they enter into their 70s and 80s will face a dementia-like illness. And so so rather than being the 1 in 50,000 state of permanent coma or persistent vegetative state, so important for us to think about something beyond a standard advanced directive to help us to express our wishes. Part of the reason that this is hard, though, is that dementia is a really complex disease. That's why Alaska Project Echo Dementia is so important, because this is a complex disease that is so varied from person to person. But generally speaking, I think it's important to recognize that people with early dementia may have many years of a very good quality of life left to live, but that they do then face a slow decrease in the quality of life as they go from mild to moderate to severe stages. And most people would want different goals for their medical care along those stages. But just so important to hold on to the value of living, especially with early dementia, that this is not like a black or white thing. Like, if I have dementia, oh my goodness, I don't want any medical care to keep me alive longer, when that's not really that's not a practical way to approach advanced care planning for dementia, because of how much the disease does change over time. And so many people do have really clear ideas about this. So this is a study that was done in Boston, where they took 200 people over age 65 who did not have cognitive impairment, and they had them watch videos that they tried really, really hard to make very balanced depictions of living with dementia. So they tried really hard to not show it as sort of too sort of awful and gloomy, but also to make it realistic, as this is what living with dementia can be like these were videos that were more at a moderate to severe stage. And 72% of the people in that study indicated that they would want comfort-oriented care only if they had that stage of dementia. And that it's just so important to recognize that that is just not what is often happening. And it's partly because it is so hard to really elicit or understand what somebody would have wanted. So how do we help people to communicate those wishes? And that's really what led me to develop a team here at the University of Washington that included people from neurology and geriatrics and palliative care to develop a dementia-specific advanced directive that we tested and refined in the primary care setting, and then made available for anyone to download for free from the website dementiadirective.org. And so this is just a screenshot of what that website looks like, which went live about 5 years ago now, I would say, where again, anybody can go to this website, dementiadirective.org, and download a dementia-specific dementia directive. And that directive has in it brief descriptions about what mild dementia is often like, what moderate dementia is often like, and what severe dementia is often like. And then below each of those descriptions, it gives people the ability to choose a goals of care option for that stage. And a really important part that was built into the dementia directive is to make it a little bit more than just a checkbox of interventions, but to include some degree of a why or value statement for why somebody might choose those 3 care options. And so with the most important one being that middle option, the no CPR, no intubation, that it's really important to recognize that why somebody might choose that goal of care for themselves would be that somebody who has a dementia illness, that if they were to have a catastrophic event like a cardiac arrest or a severe pneumonia that required them to be intubated in the ICU, that even if they were to survive such an event like that because of the intervention, they would be at very high risk of being at a much worsened state, even if they were to survive. And understanding that aspect of what dementia does to one's risks if they were to develop a severe, super severe pneumonia or a cardiac arrest really should help to inform in a value-based way what they would want, what their wishes would be if that were to occur. And so, like Chris mentioned at the beginning, after we published this in JAMA, it was written about in the New York Times, and my email address is actually on the website. And so over the years, since especially the New York Times wrote about it, I've really gotten hundreds and hundreds of emails from people all over the country saying really meaningful things like this about how much they appreciate having a dementia directive to fill out. So an interesting story about the development of this dementia directive is that early on, my sense was that the most important time to offer somebody a dementia directive was going to be when you were very first diagnosing them with cognitive impairment. So especially that person with really mild cognitive impairment who may not even qualify for a diagnosis of dementia at all yet, that would be somebody who you'd be very concerned that they were at very high risk of developing dementia in the future, so even higher than the 1 in 3 average risk. And that would be a really important time to offer somebody a dementia directive. But the experience that we've had is that it can be very difficult for somebody with even very mild cognitive impairment to fill a directive like this out. And at first I thought it was just because of that kind of initial shock of sort of the kind of, gee, this is like such a scary new diagnosis for me that I can't sort of go there to sort of imagine the future of it. But really, as the years went on and people with still really quite mild cognitive impairment who had started to become quite sort of at ease with the concept that they had mild cognitive impairment, which might even be starting to progress, and they were over that kind of initial kind of fear and shock of it, they still weren't able to fill this directive out. And I started to realize that it was more than just a psychological barrier, but it was maybe even a physiologic barrier to imagining a future state of themselves. And that rather than this being just something that they were afraid of, it might just be actually something that their brain wasn't capable of doing. And I started thinking more and talking to other experts in the field who had thought about this, that it is really a relatively high-level executive function task for our brain to imagine a future state of ourselves. And that might actually be, for many people, be one of the first things that they lose in their cognitive function early on in the course of a dementia illness. And so instead of offering it to my patients with mild cognitive impairment, I started actually offering it to all of my patients in my primary care practice over age 65. And instead of getting almost none of them back, I started getting almost all of them back, because this is really something that a lot of people have very strong feelings about. And so I really have shifted my thinking from thinking of this as mostly geared towards people with mild cognitive impairment to being actually mostly geared to people who are over age 65, where they are at increased risk in the next coming years, but who don't yet have any signs of cognitive impairment. So the next big question that I get asked a lot is the Dementia Directive legal? And here I would really sort of frame it in the way that we frame all advanced directives, and in terms of their legal status. And I really would make the strong point that advanced directives in general are mostly just general guides for families. They inform us of patients' values and preferences, but they really shouldn't be thought of as a rigid algorithm. That generally advanced directives in general are not legally binding, and instead they're really there to provide guidance for proxy decision makers and clinicians as they make decisions. And so that really helped to inform our decision to not put a place on the Dementia Directive for witnesses or notary public, because as soon as you put for witnesses or a notary public, that immediately sort of presents itself as a barrier to completing it. So somebody feels like they can't fill it out until sort of they kind of make a plan to get it witnessed or notarized. And that as soon as you put that on there, fewer of these directives are going to get done. And so there was a brilliant essay that was in the New England Journal of Medicine about 4 years ago now, with this really high attention grabbing title, it's time to delegalize living wills, really making the point that we should probably be taking witness notary out of all standard advanced directives, because of by over legalizing them, we really run into the problem of people just not filling them out, and that there's actually more risk of conflict and uncertainty if people don't have a directive than there is if somebody has a directive that hasn't been witnessed or notarized, that directive could then be later legally challenged. And so if you're going to weigh the risks, the benefits and the harm of putting witness requirements on a standard advanced directive, there really is a good argument to be made for not requiring a witness or notary on a standard advanced directive. And this is really what informed our decision to not put a place for witness or notary on the Dementia Directive. And so if somebody were to push me to say, well, what is the legal framework then for a Dementia Directive? I would say that it should be a supplement to a standard advanced directive. But if somebody hasn't filled out a standard advanced directive, I do think that a Dementia Directive would still be a useful document as a standalone document. But just about every standard advanced directive has a space at the end of it. Is there anything else that you would like to share about your preferences or wishes? And if so, then just attach it to an additional piece of paper. And so that's where I would sort of fit the Dementia Directive in its legal framework if somebody were to really push me. But I would also really strongly encourage somebody, if somebody was really worried that their Dementia Directive could be legally challenged, that there's absolutely nothing wrong with getting it notarized. So anybody can take any document to any notary public and get the notary to sort of document that they looked at the ID of the person who was signing it and that was them. And but so I think if somebody is sort of really worried about their dementia directive being contested, then getting it notarized probably does add a little bit of protection in that way. But I would not think of this as something that needs to be witnessed or notarized. And if I were to make a list of the reasons why it can be really beneficial to fill out a dementia directive, I would really say that it really is there to guide, to help people express their preferences, and really most importantly, to have a conversation with their loved ones, that this is a structured way for them to be able to sit down and have a conversation with their closest family members to say, gee, these are what my preferences are, these are what my wishes are, and if I had mild or moderate or severe dementia, I really would hope that you would take these concerns into account as you make decisions, but that it's really important to not think of them as rigid algorithms, because we can never really fully anticipate exactly what medical situations people will face in the future. And so this is not a rigid algorithm by any means, but I really do think of it as its biggest value being a facilitator for memorable conversations. And then the added bonus is that you then have documentation of that conversation, something that families can look back on later. And so now let's turn our attention to advanced care planning for somebody who already has early dementia. So like I mentioned, the Dementia Directive is really ideally geared for somebody before they develop cognitive impairment. But what if somebody already does have early dementia, but there is still like incredibly important things that you can do to improve advanced care planning for that person. And the most important form in that situation is the durable power of attorney for healthcare that sets somebody's proxy decision makers. And this is so important to designate in a legal form who somebody would want their legal proxies to be. And the real sort of value of a form like this is the ability to say who you would want as the first up proxy to be, but then who would be the alternate to that person if that person wasn't able to serve that function. And the reason that this is so important for somebody who has mild dementia is that oftentimes we don't necessarily need to have a form like this filled out, because the person who they would want is the person who it legally defaults to, which is typically somebody's spouse. And so if somebody doesn't have a durable power of attorney filled out, and it would be their spouse, and that would be the person that they would want, it's just not that big a deal whether this form has been filled out or not. But with a dementia illness, when we're thinking about it as a 10 to 15 year time course disease, it is very possible that their spouse may no longer be able to serve as their decision maker as they move into more moderate or severe stages of dementia, in which case who the backup to their spouse is may become extremely, extremely important, and they may not have any kids. And so then the person who they would want the backup to their spouse to be maybe like their best friend, who will have absolutely no legal standing to help make decisions on their behalf if they haven't filled this form out. But like I mentioned before, I think for both the Dementia Directive and for advanced care planning for dementia in general, the most important issue is to have conversations, that once somebody is at a moderate stage of dementia, gently beginning a conversation of, if that person could look on themselves now, what do you think that they would have wanted? And talking about the stress and potential harms of CPR, of trips to the emergency room, of imaging tests. And here I really would point people to a wonderful organization again in Boston called the Conversation Project, which has a conversation guide that is specifically oriented towards dementia that anybody can download for free. And so again, that's the conversationproject.org, and look for their dementia guide. And then I want to spend a moment talking about the Invaluable pulse form. And so here's an image of the Alaska pulse form, which in just this past year, or in the beginning of this year, just a few months ago, the Alaska pulse form replaced what was the working form for the state of Alaska, which was called Comfort One. And this pulse form is an absolutely crucial tool to help anchor the goals of care conversations in terms of what are somebody's goals of care right now. And so not with a dementia directive, what might your goals of care be in the future, but this is what are the goals of care right now. And this is what makes this like an order. This is a physician order that is not a sort of a more abstract guide for the future, but this is an order for medical care right now. What if somebody's heart were to stop? What if somebody couldn't breathe on their own? Is the preference for comfort-focused care? Or is the focus on ICU care? And again, I so strongly encourage embedding into a conversation like this of filling out a pulse form, remembering the value-based why. So the reason why somebody with dementia maybe would not benefit from CPR or intubation is because even if they were to survive such a catastrophic event like that, they would be at really high risk of being in a significantly worsened state, even if they were to survive. And that might not be the best outcome. Same thing with choosing a comfort-focused care option where the focus of the care is really just symptom relief only. Somebody really might choose that because of the high risk of adverse effects or agitation that are much more complicated for many interventions for somebody who has dementia. And again, really using that phrase from the Conversation Project, imagine if your loved one could look on themselves now, what might they say that they would want? So I want to talk really briefly about the role or lack thereof of tube feeding in dementia, that we have really, really solid, good data now. So multiple randomized controlled trials looking at using feeding tube in somebody whose dementia is so advanced that they're not able to take in food safely by mouth. And time and time again, in a very, very consistent way, all of those trials have shown that feeding tubes do more harm than good in somebody who has moderate to severe dementia. And in this case, this is severe dementia. So this is dementia which has progressed to such an extent that they're having difficulty taking in food by mouth. And so this has led to really strong expert guidelines, solid data-driven research. Every single national organization that has made a recommendation, a guideline about this has said hands down consistently that there really should not be any role for tube feeding in advanced dementia. And they just don't make people more comfortable. They don't prolong life. They cause more aspiration pneumonia and more suffering. And so what's hard is that sort of we as care providers can understand that and read that and understand and believe that data. The tricky part is communicating it to families that this is an emotionally sort of charged issue for many families. And the challenge then is really how to have that conversation in a caring and empathic way. And so really having wording ready to share with families, which is that something like tube feeding does not fix what is a slow dying process. It's been shown to make people less comfortable, that there has been really good research that really does show that it doesn't make people sort of less hungry and sort of more at ease. It actually increases their discomfort. It increases the amount of aspiration that they have. They don't like having that tube there and are constantly pulling it out, which itself raises all kinds of risks. And so that you worry that a feeding tube like that really would actually do harm and make somebody less comfortable and more agitated. So the key points for advanced care planning for dementia is that before dementia, so useful to offer to everyone over age 65 a dementia directive that you can download for free from dementiadirective.org. For people who have mild dementia, so important and useful to fill out a durable power of attorney for healthcare proxy document so that somebody, while they are still have capacity to fill out a form like this, can identify who they would want the alternates to, say, their spouse to be as soon as possible. Somebody who has moderate to severe dementia, immense value of filling out a pulsed form. And just remember that key phrase of imagine if your loved one could look on themselves now, what do you think they might say that they would want? Put a big plug in for primary care doing this work, especially as part of a Medicare annual wellness visit. To some degree, we might start to sort of question, gee, how important is it for somebody with more advanced dementia to have an annual wellness visit? Because you should be spending less of your time talking about cancer screening things that you would often spend time doing in a Medicare annual wellness visit, but you really should be spending that time doing advanced care planning for somebody with advancing dementia. And there's really an easy way now to add a billing code for advanced care planning to an annual wellness visit, which actually doubles the RVUs for that annual wellness visit. And it's actually the documentation to do so is really, really easy. That if you spend more than 15 minutes discussing advanced care planning at an annual wellness visit, such as discussing an dementia directive or a durable power of attorney and or a pulse form, all you have to do is add a simple billing modifier that increases the RVU for that visit but from 1.5 to 3.0 with no additional cost to the patient, no additional copay, no deductible. Here's an example of just how simple that documentation needs to be. And the wording and the codes to use for doing this are in a one-page easy handout that is on another website that I've developed, cognitionprimarycare.org. So if you go to cognitionprimarycare.org, you can download a one-pager with guidance on what billing code to use and the language to use to add advanced care planning code to a Medicare annual wellness visit. All right, so that's what I got on advanced care planning for dementia. Don't forget the website, dementiadirective.org, as well as the website, cognitionprimarycare.org. So both of those have forms that you can download and guidance that you can download for free on how to give good advanced care planning for dementia.
Barack, thank you so much. I'm going to echo Kim's and Nicole's comments that this is indeed excellent information, both the resources, the tools and the scripts. I mean, these are such difficult conversations, and to have, I think, just some verbiage at the ready to help facilitate that and the importance of revisiting things both early and then over time. So helpful. I'm curious, let's see, we've got a few minutes for some questions, comments. Feel free to unmute and jump right in. I see one in the chat from Gay.
Yeah, and this is Ursula. I'd be happy to answer any questions about Alaska Pulse, specifically like Gay's question.
Please do.
Would that help? Okay, I'll say, so Gay Wellman wrote, how is the Pulse form being sent around to providers? Is this a form people can fill out themselves? Or is it going to be done with an interview? And should we be asking these from our providers now? Okay, so Comfort One will still continue to be honored, but they will no longer be resupplied starting in June. And Alaska Pulse is a form that's downloaded off a website. So providers get it off the website. And the website to know, I'll put it in the chat, is akpulse.org. And on that website, there's a tab for providers that has all the frequently asked questions and how to use Pulse and a link to the regulation, because these are statute and regulation backed programs. And there's also on this website a section for patients and families around education. And there's nice videos about Pulse and advanced care planning. And there's some brochures for patients and families. And right now we're looking, because Comfort One used to be ordered from DHSS. And so they were packets of this triplicate form and a brochure, and that we're asking DHSS to still provide pulsed and brochures, but at this time that infrastructure is not set up, that people are just downloading them. Each individual office is downloading a pulse form, downloading the patient brochure. And we're also using these pink envelopes. Let's see if I'll hold one up. That we're starting to do as a culture. And am I on the screen to see video? Can you see this? And so this pink envelope is something we're asking patients and families to keep the pulse in, so EMS has a better chance to identify it. Can you see that now? And so let me hold it here by my face. ASHNA is a big partner in this pulsed education, and they're going to be distributing these packets of the pink envelopes, pulsed forms. Patient education is going out to all of the hospitals in Alaska. And if anybody would like for your own group, I have a supply of these packets. If you would indicate in the chat, and I'll take down your email and get in touch with you about how you could have these as well. And the hope is that the state will take over this this kind of mailing, the operational side of these brochures, because that worked really well for Comfort One, that everybody that ordered them got everything they needed to do the Comfort One. And right now, Pulse, it takes a lot of work for the providers to find them and download it and to use it. But that's the status of Pulse in Alaska right now.
And I guess I would just sort of chime in that it's like so wonderful that that Alaska has made this change, and that but back to the question of sort of, is this something that people fill out on their own? I would generally sort of point out that a pulse form, because it's a physician order, it really is something that should be filled out with a physician. And so the physician ideally helps to guide through like filling the form out and making sure that the physician orders accurately reflect what should be done. And then it gets signed by both the patient or their proxy and by the physician. So the physician needs to sign it for it to be a valid physician order.
Excellent points. And looks like there's a question and answer in the chat also about these going to tribal or native clinics as well, not just hospitals. So that's excellent. Other questions or comments before we shift to a very kind of congruent case by Barb Bigelow?
I'll just add for the Pulse program, a lot of the work was done around setting up the regulation and modeling the program after National Pulse. But what we don't have in Alaska is anyone who has a job, whose job it is to implement and run a Pulse program, just to name that. And so like I've been part of a group of volunteers that have put together the website for education, but it really is a grassroots, like now and now you can look up what it is on the website and get informed, and you might have to teach somebody else kind of what this is. There is a public information campaign that DHSS has been running to kind of do all of the outreach to all of the all the medical societies in Alaska and all of the clinical providers. And then they're going to start public outreach probably sometime this summer. They wanted to give the providers, the clinicians, the information first. So you might be seeing some of that kind of coming out, but to just sort of empower us all that we're all kind of owners and making a Pulse program work well. And the website is a good foundation of this. It's tied to DHSS, so it's the most up-to-date, accurate information about Pulse for Alaska that has information for both clinicians and patients and family members.
Excellent. All right. Well, again, with I'm guessing, given that our case is about pulsed forms, we can maintain and continue this conversation. Barb, thank you so much for being willing to do this presentation. I'm happy to run the slides if that works for you.
Yes, please.
All right.
Yes.
Hopefully you can see those okay.
Okay. And can you hear me okay?
Sound perfect.
Okay, so apologize. My screen and my monitor, my camera are not well aligned, so it looks like I'm looking away from you as I kind of watch the screen. So, you know, I started this series before when I was a nursing home administrator, and now I work with Mountain Pacific Quality Health. And initially I thought, you know, I have a story, but it's a personal story. And I didn't have a clinical story, but over time and through these series, and I think this is the most valuable echo I've ever participated in. And I really want to thank you for hosting this. So I am going to talk about POLST, was part of the implementation committee at the state level, but also going to talk a little bit about a case presentation, which is my mom. So a story is an account of past events in someone's life or the evolution of something. And I have thought a lot about stories. And when I meet people or I get to talking to folks, I sometimes just say, tell me your story, because it's a way of saying, I'm really interested in you and I want to know what's important to you and what your story is. So next slide, please. But I'm also going to talk about POLST. And as Dr. Gaster and Dr. McVeigh have also spoken today, really it dovetails with this. Some of the things I was going to say have probably already been said, so I'll try not to repeat too much, but we do finally have an Alaska POLST. It was passed into law in 2021, but implementation began at the beginning of this year. So it takes time to roll out POLST and get it to all the folks who really need to understand it and know what it's there for in terms of our providers. So next slide. So, you know, I've given this presentation several times and I always weave a little history into it because I think it's really important, and especially younger professionals don't realize what preceded the Patient Self-Determination Act, which is really codifying advanced directives in our country. So Ann Quinlan was the first, 1985. Her death and her parents' battles really kind of set the stage for continued conversations or what used to be debate around the right to die. Nancy Kruzan is a young woman, very interesting story. I wrote a paper in grad school about Nancy Kruzan. She had, and I said near-death experience because she landed face down in a cornfield, and she was resuscitated, brought to the hospital, and it took 7 years for her family to allow the right to allow her to die. And this case is really famous for the National Right to Life Coalition and their interference with the courts. And then Terry Schiavo came after the Patient Self-Determination Act was passed, but she did not have an advance directive when she ended up in her state. And it took a long time because her parents and her husband disagreed on the course, which is why advance directives are so important. Okay, next slide. Patient Self-Determination Act was passed in 1990. It reaffirmed the common right law of self-determination as is guaranteed under the 14th Amendment. It sets rules for healthcare providers to ensure that a properly executed, legally valid advance directive is honored. It's really interested to hear what Dr. Gaster had to say about delegalizing advance directives. And, you know, maybe that is the next place we are going in this country as we talk about the right to formulate advance directives and how we wish to be treated. So in Alaska, it still needs to be a witness document, but I like the idea of coupling the dementia. And then, of course, anything with power of attorney has to be a notarized document, at least in Alaska. Next slide. We were in Alaska. I know many of you on this call are from another place, but we were one of only a very small handful of states that had not implemented a statutory POLST. And it's known by different things in different places, but the intent is the same. It's the ability of an individual to direct the care they want at the end of their life, and that includes dementia care planning. It was signed last April, and rollout began the beginning of this year. So, and it really, what it does is it repealed and readopted the DNR statutes in our state. So next slide. The Alaska Pulse, what's really important to remember is that it's actually a medical order. It's not an advanced directive, and it's portable. So it is recognized across healthcare facilities, and it's incumbent on a healthcare facility to honor the tenets of the Pulse. We do have a registry under development, but I think it's going to be a while before we actually see a statewide registry for Pulse. Currently in Alaska, advanced practice professionals can complete the Pulse with their patient resident, but it has to be signed by an MD or a DO. And you know, the professions that explain these, physicians, assistants, social workers, nurses, there's a whole cadre of people who work directly with patients around end-of-life decisions. So it can be explained by any number of professionals, but again, has to be signed by an MD or a DO. Okay, next slide. Chris, you can go to the next one. Thank you. So I wanted to just recognize, Terry Cadell, the Alaska State Hospital Nursing Home Association, the Washington Pulse team, and other providers were involved in putting this together for the last, I would say close to 2 years. And then special recognition by myself goes to Dr. McVeigh, Dr. Mailer, and Sharman Figenshaw, who was with the Washington Pulse Task Force, and she helped a lot with the educational presentations for Pulse, which have been going on week by week. So really trying to get the word out. Okay, next slide. All right, so Lou's story. You know, I want to thank Kimberly Jung for her presentation a couple of weeks ago. She really kind of inspired me to, I loved hearing her story, and you know, in the end run, it's really about families and who they are and the choices they make. So this is my mom, Lou. That's her in the arms of my grandmother in 1931. She and my father in about 1961. And then these were the 3 children, Barbara, David, and Carl. So they had 3 children together. And I want to tell you something about my mom's advance directive. So when the Patient Self-Determination Act was passed, I was working at Fairbanks Memorial Hospital. That was prior to Banner. And I know it's not Banner anymore, but this is a long time ago. And I worked with a hospital chaplain, and we implemented the living wills and did the education and wrote the brochures. And it was really an interesting time in getting the information about the Patient Self-Determination Act out. And I brought it back to my family. I talked to my dad and my stepmom. I talked to my mom and her partner. I talked to everybody I knew about advance directives to say how important it is to have an advance directive and to think about these things when you're well. So if you're in a situation, a difficult situation, you've already thought about what you want. So one day, a few years before my mother's dementia started, we were looking at her advance directive, and she had selected that she wanted artificial nutrition and hydration. And so as we had this conversation together at her dining room table, I said, "Mom, why did you select that? Do you understand what it means? And you know, what are you thinking? Tell me why you did this." And you know what she said to me? She said, "That's because the attorney told me I should select it." So that was really telling to me, where somebody's personal bias or ignorance could influence someone in maybe not. So we went through the process of talking about it, and I did my spiel with what it means, and in the end, she revised her advanced directive and she deselected those, and we got a new advanced directive and sort of started over. So my mother's dementia really, she had a lot of health issues. There was some brain stuff going on. I thought, but I wasn't sure. So I took her to a geriatrician in Portland, Oregon. I was working with Peace Health, and there was a wonderful geriatrician, and we'd started a program. And I wanted him to evaluate what I thought were gait issues and some chronic pain issues and different things. And after that, he took me aside and he said, I think your mom's having some cognitive impairment. And that was the first time I really had started that journey in terms of that. So next slide. So the balance of the story, and it's not important that I tell the whole story, but it really is about the journey that we started together, my mother and I, and making her quality of life and progression into dementia as positive as it possibly could be. So she, dementia is just a horrible disease. And she progressed from leaving her home on 20 acres where she lived independently in rural Idaho, very strong woman, to senior housing, to assisted living, and eventually to a nursing home where she died. And the whole progression was about 10 years, but the difficult part was really about the last 6 years. And the picture on the lower right side, I don't really like selfies, but I was trying to get a picture of us together. And I have a smile on my face and she looks horrified, and she's not horrified because she didn't want her picture taken. She's horrified because dementia has robbed her of her life. And it is just it's just a horrible disease. Okay, next slide. So then my mother's advanced directive planning helped inform what eventually was a post, an Idaho post, physician's orders, which became really the foundation for the balance of her care planning. She had a wonderful primary care doc in Idaho, and one day I said to him, I said, Kelly, she's like on 10 different medicines, and this doesn't work, and this is causing dizziness, and blah, blah, blah. And pretty soon Kelly's like, yeah, you're right, Barb. And we started weaning her off. And so there's just, there's so much really good work that can be done that's non-pharmaceutical. But she eventually entered hospice in the nursing home where she had resided for the last 14 months. And I was on my way up north for work, and the hospice nurse called me and said, Barb, I think you need to come to Arizona. And I've been coming regularly the whole time she was there. But I walked in and she's sitting in a wheelchair at music, asleep. It was really tough. I knelt down by her wheelchair and I said, Mama, I'm here. And she looked at me, and the very last words she said were, oh, good. And then we took her back to her room, and she died 4 hours later. I'm absolutely convinced that my mother was waiting for me to die, and those stories abound. And then this photo my niece took. So we had her celebration of life about 6 months later, and I went to her backyard to scatter her ashes, and my niece was taking pictures. And as I threw the ashes out, I just raised my arms and said something to my mom, and this is what the picture showed. And I'd be hard pressed for anyone to tell me that wasn't my mom's spirit right there in front of me. So I think it's an amazing photo, and I wanted to kind of share that with you. So next slide. And that's all I have to say. If anyone has any questions, I'm happy to entertain questions. Thank you for listening to my story.
And thank you for sharing it. And it does look like there are a couple of questions about, oh, very good point about possible barrier in terms of needing to be signed by an MD or an OD or DO. And is it the case that ARNPs can sign in Alaska? Any comments on that? Not yet, it looks like. Okay.
Yeah,
Ursula?
not yet, but there's an active House bill. It's physician only. We need an addendum to a statute because in our law from 2004, it states DNR is a physician order.
Right.
And if people want to message me too, it's active, it's passed the House, it needs to pass the Senate, and it's greatly threatened by having alternative agendas being introduced to the healthcare statute that don't promote good end of life care.
Yeah.
Barb, do you have more to say on that?
No, but I think it was, you know, we need advanced practice professionals to be part of this work. So I'm totally supportive of it. Yeah.
Is there a anticipated timeline for when that will be finalized, or depends on session?
Yeah, we're hoping to get it in before the end of this session, but it's almost been pulled because of alternative agendas. Anything with healthcare being tried to pass through state law can get distorted, greatly distorted by what it looks like when it comes out. So its biggest risk is that it'll be distorted, and all the advocates that want this in place will pull the bill because it's not worth jeopardizing other areas of how we care for people at end of life. But it's a really necessary thing, and there's just been a lot, if anyone is active in politics, there's been a lot of imploring our representatives to only do this. Just this one addendum around the signing authority for advanced practice providers. For how Gabe put it, it's essential to care for people in rural areas where their primary care providers are advanced practice professionals. So it's this week. It's been a little dramatic. So if anyone has connections with it's the senators we need to be connecting with and giving them information about why this is important to just do this in our healthcare statute update.
Yeah.
This is Gay. Can you, Ursula, would it be possible for you to send around or put in the link, you know, verbiage or something that we can say that quickly to our representatives? Because this sounds really important.
Yeah.
And I guess my other
way to do that.
Yeah. And the link, or you can send it, if I'm the only one interested, you can send it to me. I can put my email in the chat box here, but I see a PA, and it sounds like it's something that I would really like to be doing for myself, as well as helping my clients, the clients that I see. And I'm thinking about my sister who's down in North Carolina, and I would love to be able to do one of these for her. She's to the point where she wouldn't be able to do it herself, but I think it's so important that these be followed. I hate the idea of her being kept alive forever and ever if we don't do something like this. So I just wonder if there's, I'm hoping that this kind of information will get out there, and certainly it sounds like it would be something that I would need to wait to do for myself until I can get to a doctor.
Bryce, I know we're right at 2 o'clock, but I see Barack's hand is up and his head is shaking. So
yes, don't wait till you see a doctor. Fill it out now. And it just goes back to the slide that I had about pulse in my presentation, that the pulse is, yes, it's important as a physician order, and that definitely gives it tremendous weight, and it should be signed by an MD or a DO. And yet it has tremendous value just as a communication tool, even if it's not signed by the official sort of, person who it needs to be signed by. And because the reality is that even if somebody has a signed pulse form by an MD, if they show up in an emergency room, then that new code status does need to be reset anyway. But so the value of the pulse form in that moment is not as necessarily a physician order in the emergency room as much as it is a communication tool that shows somebody what somebody's wishes were.
Excellent point. All right. And Ursula, I think you are on for our last session in 2 weeks, and maybe we can follow up on the topic of where things stand in Alaska at that point too. Hopefully we'll have more information. But thank you all for, well, Barack, thank you for the didactic and the presentation. Barb, thank you so much for the case and sharing that piece of your personal story. You're right. Nothing more important than family, and a good reminder of why we do this. So, all right, thank you all, and we'll see you in 2 weeks for our final session. All right, take good care.
Thank you.